It's the Brian Lehrer Show on WNYC. Good morning again, everyone. If you've needed admission to a hospital in the past few years, you might have spent hours, even days, in the emergency department first while waiting for a real hospital bed. Dr. Elizabeth Rosenthal, senior contributing editor at KFF Health News and former ER physician, wrote about the issue of emergency room boarding, as it's known, for The Atlantic, and we'll talk to her in a minute. In 2024, by way of background, her husband, Andre, was admitted to the emergency room, the emergency department, for complications from esophageal cancer. After 36 hours in the ED on a stretcher in the hallway, he finally got a bed, quote, upstairs, which itself turned out to be an overflow area that lacked enough personnel. For the last months of his life, Rosenthal writes, her husband's mantra became, I will not go to the emergency room. One director of emergency medicine told her that hospitals now run like airlines and intentionally overbook in order to make money. The problem is in the way healthcare finance is structured, her source told her. It can increase the anguish of people who find themselves in emergency department limbo, who may not get a bed or have any semblance of privacy. And worst of all, it can lead to some patients falling through the cracks, which, of course, can be not just an inconvenience, but hazardous to their health. Joining us now to discuss her latest is Elizabeth Rosenthal, senior contributing editor at KFF Health News and a former ER physician herself. She's also author of the book, An American Sickness, How Healthcare Became Big Business and How You Can Take It Back. This new piece for The Atlantic is titled, A Barbaric Problem in American Hospitals is Only Getting Bigger. Dr. Rosenthal, welcome back to WNYC.
Well, thanks for having me.
And listeners, we want to invite you in on this as well to help report this story. For those of you who work in emergency departments or patients for whom this sounds familiar, we invite your stories as well as your questions. How has ED or ER boarding changed over the past 5 years, in particular if you work in a hospital? For those of you who do, what are you noticing and how is it impacting your jobs and your patients? So nurses, nursing assistants, doctors, directors of emergency departments, anyone else relevant, help us report this story. 212-433 WNYC, 212-433-9692. And again, patients or caregivers of patients who've been to the ER, if you had a recent experience you'd like to share, we invite that from you too. Did you spend many hours, maybe even a few days, in the emergency department recently? What was that like, and what would you like others to know about your experience that may help make things better? 212-433 WNYC, 212-433-9692. You can call or you can text. So, Dr. Rosenthal, as I said in the intro, you opened the piece with your husband Andre's mantra in the last months of his life, I will not go to the emergency room. And so, first of all, I'm sorry for your loss. And you're right that you understood that his adamant rejection came because most prior visits had, as you write, morphed into extended trips into a terrifying medical underworld, to a purgatory known as emergency department boarding. So tell us what boarding is and what the 36-hour experience was like.
Well, boarding is if a patient goes to the ER, which is the front door of hospitals for every patient now, and it's determined they need admission. And then the question is, okay, is there a bed available for that admitted patient on a ward? And the problem is there are too few beds for the patients who need admission from the emergency room, particularly if they're older or sicker. And we'll go into the finances of that later. And so they park these patients, like my husband, who, had stage 4 esophageal cancer and was dying, on a stretcher in the emergency room. Maybe you're in one of the bays. Maybe you move to the hallway. Maybe you move to the an ER overflow area. Technically speaking, you're admitted, so you have some physicians, a team upstairs who knows about you, who may be writing orders, but if you say, hey, I need to use the bathroom. And remember, there are only two bathrooms for everyone in an emergency room, or I'm short of breath. It's very unclear who needs to respond to that. And ER physicians and nurses have complained bitterly about this for years. It's not, it existed to a smaller degree in the past, but it's just grown and grown, particularly since the pandemic. And it's just awful. I mean, that admission you're referring to, my husband was confused. He was still getting treatment, and it was unclear if the cancer had gone to his brain, which it hadn't, but he needed an inpatient evaluation and to get his mental status better. And as you can imagine, I mean, this is a guy who was totally compos mentis the day before. Uh, and he was a little confused, but 2 days in the emergency room, stuck on a stretcher, rails up, as I said, not being able to get around, not knowing whether it's day or night, codes going on, alarms blaring. By the end of the second day, he was convinced that, the doctors were like somehow in a conspiracy to get him, and I was their paid accomplice. So I was like, how can you, why would you go back to something like that? It's just, you come to an emergency room if you need admission because you're seriously ill. And what you get is not good medicine. And I think ER doctors have been writing about this. The American College of Emergency Medicine has complained about it bitterly. And I just wanted to show what it feels like to be a patient or the loved one of a patient going through this experience. And it's awful. And I'm sure everyone, says, oh, yeah, I waited 4 days at this hospital, or I waited, 2 days next to a corpse at this hospital. And I think so many of us have experienced it, but we're not really near a solution, which takes a lot. It's not really only the hospital's fault or only, and certainly not the doctors or the patients or the nurses' fault. Everyone's trying to do their best in terms of the personnel. But, hospitals are partly to blame, but we have to talk about the larger system to really understand what's going on here.
And so when you pushed to move him to a bed upstairs, as they call it, he was, because emergency rooms are almost always on the ground floor, he was transported to what you describe as an ED overflow area on a former labor and delivery floor. You write that it was kitted out with some of the trappings of an actual ward, such as real beds and bathrooms, but not the most important one, adequate personnel, unquote, from your article. You write that two people died in 3 days in that room. How widespread is this kind of improvised overflow arrangement?
Oh, totally widespread. I mean, and you're kind of lucky if a hospital tries that solution because at least you're not in some, hallway on the way to radiology for 2 days. But, you get an actual bed, but it feels like a kind of, and I don't say this lightly, a warehousing of patients who have no hope, who are destined to die or have dementia. And I think the most striking thing to me in that the days he was on that ward was, I said, gosh, his sheets haven't been changed in 3 days. And the nurse looked at me and said, well, there's the linen cart. I'm like, oh, okay. Is this what we're paying, $2,000 a night for? And they did eventually come and change it for me, but it was pretty nightmarish.
Let me take a few stories from listeners, and then we'll get into more of the structural reasons that it's like this and what you think can be done about it. Let's go first to Tara in Metuchen. Tara, you're on WNYC. Thank you for calling.
Oh, thank you for taking my call. Can you hear me okay?
Can hear just fine, Tara. Thanks for calling.
Awesome. A couple of years ago, my daughter had a mental health crisis, which brought her to the ER at a very good hospital near us. She was 16 or 17, so this took her to the pediatric ER, but really, she was by far the oldest patient there. And because it was a mental health situation, she was put in a special room off in a corner of the emergency area. The room had no windows. Out the door, you could not see any light from outside. She was stuck there for, 3 nights or maybe 4, waiting for a bed to open up in another facility, a proper mental health facility. And during that time, she was just basically rotating between screaming and shouting and being medicated and sleeping and awake. And it was completely horrific for her, for us who were with her. Again, she couldn't get outside for a breath of fresh air. She couldn't see the outdoors. She really could not leave her room. It just was, I'm pretty sure she has PTSD from that experience. We probably do too. She pretty much now refuses to go to the emergency room if needed. It was not a good experience.
Tara, thank you very much. Disturbing as that is, it's probably useful for people to hear it from you in that way. Let's go to another patient with another story, actually a story of one way that he's getting around the kind of thing we've been describing here so far. Jack in Westfield, you're on WNYC. Hi, Jack.
Hi, good morning, Brian. You're a national treasure. For your guest consideration, my mother is an 85-year-old Alzheimer's patient, and so she's in assisted living. And whenever she has a fall, which has happened about 6 or 8 times over the last year, she gets transported to the hospital, which is the standard protocol for the facility that she's in. But they normally transport her to a Trauma One, North Jersey, very good hospital in a very wealthy part of the state. And we have literally stopped having her sent there, and we choose for the local community hospital, which is really not the best place for for stroke care or cardiac arrest care, because the situation is just as your guest has described. You get assigned to the orange section, location 5, or you're in the red section, location 2. You're there for 36 hours. It's very difficult to get information from the nurses and doctors who are working really hard, but it is literally, it's almost like the Port Authority bus terminal at rush hour. And so my siblings and I have decided, for our sanity and for our mother's sanity, because there's no privacy, and, we just say, you know what, let's go to the local community hospital where we know she's going to get a room. We know the PET scan of the head and chest is going to come back negative, and we'll get her back to where she lives as soon as possible.
Jack, thank you for telling that story. Dr. Rosenthal, do you think that that's a way out for many people? Obviously, it depends what kinds of hospitals are available in any given area, but maybe people have an assumption that the larger, big-name hospitals are going to be the places for better care. And maybe it is some of the smaller community hospitals where, people may not think they have as much to offer, that don't have this emergency room crowding or boarding issue. Or maybe Jack's is a one-off. I don't know.
No, I think he's pointing to an important hack. The problem is, what do we mean by better care? The smaller community hospitals are, in fact, not the places that have big problems with ED boarding. It is the big, famous medical centers, the level 1 trauma centers. But, if you're in a situation like like Andre was, where you're getting complicated cancer care at a particular hospital, that's where you have to go, right? So if it's something simple, sure, you can go to the community hospital. You'll get a bed much quicker there, but you may not have the expertise that's needed to be treated. And I think, we can talk about the reasons why it is these big, impressive hospitals that have the biggest problem.
Well, let's talk about that. And listeners, if you're just joining us, My guest is Dr. Elizabeth Rosenthal, senior contributing editor at KFF Health News and a former ER physician who wrote about the issue of emergency room boarding, that is, staying in the emergency room for many hours or even days before you can get a room upstairs, as they call it, in a regular bed. Wrote about this for The Atlantic, and her article is called Barbaric is a quote that we're going to hear why in a minute. A barbaric problem in American hospitals is only getting bigger. So the question of why. You went back to your old colleagues to ask how this happened. An ER doctor at Boston's Beth Israel Deaconess, Adrian Heimovich, told you, quote, everyone knows about this problem and no one cares enough to do anything about it. It's barbaric. That's where the strong word in your headline comes from. So What's your understanding of why this is the case?
Well, it's really multifactorial. I mean, one thing, as we said in the story, is that hospitals run like businesses, right? That's what I've been writing about for 30 years. And, if you want to have beds available for ER patients, you don't want to run at 100% capacity. You want to run at maybe 90% capacity, so there'll be beds available. But from the hospital's business standpoint, that view, an empty bed is a money loser, right? It's staffed, it's sitting there, you got oxygen. So you want to keep those beds full all the time. So now hospitals run at 100% capacity or near it if they can. When I was an emergency room physician, and this was now decades ago, if the hospital was full, they would cancel elective admissions. Now, no hospital does that because those elective admissions that need beds, those are hip replacements, they may be a heart procedure. Those are big money makers. So you want beds filled with people who need lucrative care, right? So that's one reason why they're full all the time. And another reason why it's so hard for the patients in the emergency room is if you're older or sicker, or stage 4 esophageal cancer or any other cancer like my husband was, you can go to a bed, but you're not gonna be a big moneymaker. You likely don't need anything that's, a big procedure or an operation. You just kind of need a tune-up and some evaluation. And that's not very lucrative, and it takes a lot of time because you have to schedule tests with radiology that may not be able to do them for 3 days. And the more systemic issue is, even if those people are cleared to go home, there's an enormous shortage of rehab beds in this country. They very likely can't just go home to their previous living environment if they've worsened or their condition has worsened. So we don't have rehab beds. We don't have what we used to have, transition units, which help people, are a kind of lower level of care unit to transition out of the hospital. There's an enormous shortage of nursing home beds. So that's a factor we have to deal with. And beyond that even is, hey, if it's determined you need to go into hospice, which we were trying to arrange for my husband, you need to get insurance approval because your insurer may only have contracts with certain hospice providers. And that's a whole thing. And then if you're on Medicare Advantage, for example, they can say, oh, we're denying this transfer to rehab. Maybe we don't think you need it. And you have to be in the hospital 3 nights in order to qualify. So then they deny it, then the hospital appeals. So those patients can block a bed, producing no income for days and days on end. So it's a complex problem that is solvable, but as Dr. Heimovich said, nobody cares enough to solve it.
Let's hear another patient story. Tom in Manhattan. You're on WNYC with Dr. Rosenthal. Hi, Tom.
Hi. My experience is not as extreme, as some of the other patients, but it just typifies what a kind of standard situation is for someone. I'm a transplant patient, so I'm immunosuppressed. A transplant has a lot of sequelae, little things that happen, infections and stuff like that. And in order to get treated at the big hospital, big, wonderful hospital, I have to go through the emergency room. And each time I go through the emergency room, I'm subjected to an environment which is filled with all sorts of germs which put me at risk. And I'm there from between 6 and 36 hours. So if anything goes wrong, I have to go through this limbo each time it happens. And that's just the system. There's no other way around it. It's not the right way to operate. I got to tell you I'm in there with people who are sicker than me, much sicker than me, not as sick as me. There are hundreds of people in the various bays of the emergency room, all of whom are in the same boat that I am.
Sounds very frustrating. Did you ever ask anybody there, the staff, why is it like that? Was it always like this? What can we do about this? I know it's not really up to them because it's structural, but have you?
Well, the emergency room staff, they are wonderful. I mean, that goes without saying, right? They're heroes. They just take what they're given. That's just their job. The people who are in charge of the program that I'm on, just don't. They say we don't have any choice. This is the only way we can admit you to the hospital. And they
Tom,
guess it.
Mm-hmm. Go ahead. Sorry.
I was just going to say. I guess that comes from the hospital administration.
Yeah. Thank you for your call. I appreciate it. I'm sorry you're going through this, but again, it's good for people to hear that story at that level of detail. And so, Dr. Rosenthal, you write in your Atlantic piece that hospitals today run like airlines and intentionally overbook. Gabe Kellen, if I'm saying that right, the director of emergency medicine at Johns Hopkins, told you the problem isn't inefficiency, it's the way healthcare finance is structured. So is that new? Because I think part of your point is that when you were practicing in the ER, it wasn't always like this.
Yeah, well, remember, I converted to journalism in the early 90s, so it's been a long time. But yes, a bunch of things have changed. I mean, hospitals have huge administrative staffs. They pay their CEOs a lot of money. They need to pay nurses more post-pandemic, which they probably should, right? Nurses have been underpaid for years. But as I said, there were a couple of things when I was an ER doc. The hospital, would cancel elective admissions if there weren't enough beds. They didn't run at full capacity. They went on diversion, meaning we won't take any more ambulances because we're just filled to the gills until we can get some of these patients out of here, either discharged or up to a room. And the big problem that the last caller refers to is physicians on the staff of hospitals used to do what were called direct admits. They would decide a patient need to be admitted and get them a bed assignment, and they would go to an admitting office and go up to the bed. Now, hospitals have decided that every admit has to come through the emergency department, so they get an ER evaluation. I don't know, you could argue that it's to make sure the ER docs are making sure that they really need to be in the hospital. But there's also kind of a financial motivation to do that. I mean, you get a lot of money for ER evaluations. I noticed on my husband's explanation of benefit statements, we were charged, as if he were in a hospital bed each day he was boarding in the ER. So they make money doing that. And then, eventually they get up to a bed on the floor. But if you have a burst appendix or a hot appendix, you'll get that bed pretty quickly. But if you're maybe an older diabetic person with a foot wound that needs antibiotics and dressing changes for a few days, that you lie in the corridor and boy, no one, people like to talk to the doctors and say, what can you do? But I think anyone who's watched The Pit, one of the subplots that people like me notice is Dr. Robbie following the administrator around saying, get some of these people upstairs, get them out of here. It's not good medicine. We can't take care of people. We can't take care of new patients. So the physicians, both your primary care physician or the person who's caring for your transplant, nor the ER doctors really have any power over this.
Here's a text from a doctor who writes, "Thank you for bringing up this topic." And he or she adds, "Sorry for your loss." And writes, "I am a physician upstairs and worked for a major New York health system for 25 years. This problem has been going on for 20 plus years. One year when the hospital I worked at had an average occupancy rate for the year of 103%, meaning more patient days than bed days. It had an operating margin of 2%. This was, I think, around 2010. Economics requires that hospitals are more than full to break even. Agree this is a terrible problem, but I don't know what the best next steps are. As things are, we can't afford the care offered. I'm all for single payer at this point," writes that doctor. So to finish up, the one concrete policy step that you report on in your Atlantic piece is a new rule that begins with voluntary reporting of boarding times in emergency rooms. That would start next year and become mandatory in 2028 with Medicare reimbursement penalties for bad performing hospitals starting a couple of years after that. So tell us a little bit of how that would work. And do you agree with the doctor who wrote in that single payer would be full or partial cure?
Well, first of all, I'm a journalist, so I can't say I agree that the solution to the U.S. healthcare problem is there are many, including single payer, and we are doing none of them. So that's what I'd like to say. In terms of this new program that did go through at the end of the Biden administration, there was a report on emergency room boarding that suggested that a panel be convened to figure out solutions, which are not easy. The Trump administration came in. The DOGE program kind of decimated that particular part of CMS, and the panel never happened. But they did implement a rule that you're talking about, why wait 2 years for mandatory reporting? And then this kind of nebulous Medicare penalties. I think the problem is there's so much money to be made, and I'm sorry to talk about this in financial terms, but this is how the bean counters see it. To be made by ER boarding, even though it's horrible for patients, how big a penalty my worry is the penalty will be like, okay, fine, we'll pay that.
Right.
And also enforcing hospital compliance and collecting this statistic.
But just one quick follow-up, and we've got 30 seconds. When you say and others say there's so much money to be made, at least in New York, the hospitals are nonprofit. So presumably they're trying to do whatever they can to work with those small margins that the former ER physician wrote, or the upstairs physician wrote about, rather than trying to, quote, make money because they don't have shareholders or owners. What would that question miss? 30 seconds.
That question would miss that most nonprofit hospitals work like businesses. And, you go into the lobbies of these hospitals and, the big marble lobbies, the good art, the pianos, they don't look like nonprofits, and they don't act like nonprofits. They define their profit as surplus, and they build more things and they pay their executives more. So there's a massive need to restructure how we think about what a hospital should be too, so that, yeah, they run on narrow margins, but they also spend money on a lot of stuff which isn't essential to healthcare, and that's all wrong.
Dr. Elizabeth Rosenthal, author of the book that originally came out in 2017, An American Sickness, How Healthcare Became Big Business and How You Can Take It Back, now has her piece in The Atlantic called A Barbaric Problem in American Hospitals is Only Getting Bigger, about boarding in emergency rooms. Thank you for sharing it with our listeners.
Oh, thanks for having me. It's such an important topic.
WNYC Studios is supported by AT&T. Summer. It's when we share more time, more memories, and more photos. And at AT&T, the iPhone 17 Pro is your summer essential. Its center stage front camera auto-adjusts the frame to fit everyone into group selfies. Right now at AT&T, you can get iPhone 17 Pro for $0 with eligible iPhone trade-in, any condition. Required trade-in of iPhone 15 Plus or higher, excluding iPhone 16e and 17e. Required eligible plan. Terms and restrictions apply. Subject to change. Visit att.com/iPhone or visit an AT&T store for details.